I think he's a world leader in physical therapy and has a PhD and has several PhDs working for him.
I'm going to talk mostly about physical therapy management of people with Ehlers-Danlos syndrome. And when we see patients in our office, it is so obvious. I can usually tell within 5 minutes that someone has Ehlers-Danlos syndrome. These people never sit still. They put their legs in position that I couldn't even dream about doing it. Very commonly, if you look at the biomechanics of how people with Ehlers-Danlos tend to function, they present with asymmetrical arm swing. They're not symmetrical. They don't walk normal like other people do. Many people with Ehlers-Danlos syndrome have constant hip and knee flexion while they walk. They may be internally rotated at their hip. Very commonly is excessive ankle pronation. Proprioception and muscle torque deficits are very, very common in Ehlers-Danlos patients. They don't know where they are in space. When they want to move, they don't know where their limb actually is. And they very commonly move very quickly out of that mid-range of motion. And it takes a lot of work and a lot of dedication to get to that point that it becomes natural. But they still have lots of posture issues. That they can't figure out where they are. There's a girl who was treated recently, 17-year-old. When I looked at her, she could not stabilize herself. Now, forward head posture is very common in a lot of these kids. So from a physical therapy perspective, it's very functional. I think of it very functional. We're going to look first at function, then we're going to look a little bit about what to do with pain. I teach all my patients that they need to learn to live in mid-range of motion. They can't change the hypermobility. There's no such thing. And the ideas of strengthening neck muscles to stop this, it's not going to work. I mean, I totally agree with the previous speaker earlier this morning. That's just not going to work. More peripheral joints, yes, you can probably do a lot with strengthening. And people are always told to do strengthening, and we'll get back to it a little later. But what most physical therapists do does not work because they're in too much pain. They're told to strengthen, but they're in too much pain to strengthen, so therefore the strengthening doesn't really work. So let's talk about mid-range of motion. Here you see one of my patients with quite a lot of trouble. We often prescribe ring splints. Here you see some over-the-counter ones, so very commonly I prefer to make customized ones. This is one of my patients. It's hyperextension of her thumb that interfered with her ability to play violin. The silver ring splint took care of that. We had to pad it on the other side because she would go along the neck of her violin and would scratch, and that wouldn't be very good. But it solved the problem. So if we look at joint stability, very commonly we have to give them external devices, like braces to help. Because then we do a lot of education. And every time you yawn, to put your tongue against your palate, to avoid overextending your mouth. So you would dislocate. And that's one of the things we teach people. Put your tongue against your palate when you yawn. Don't bite into an apple. You're going to dislocate your jaw. Heavy doors, don't open them with your outstretched arm. Because if the door is a little heavier than you anticipate, all you will do is make your arm longer. And the door will still be closed. Physical therapists know extremely little about pain. But if you look at this is from a very recent book. Waiting for the pain to go before returning to physical activity is not going to work. Because inactivity and abnormal movement are the two most important driving forces for pain. I don't believe that for a second. I think that is a totally incorrect paradigm. That sets up your patients with Ehlers-Danlos to absolutely fail. Because what they're told, you need to get strong. You need to get your muscles strong and fit. The pain is the last thing to improve and only does so slowly. I would argue that pain should be the first thing to go away so that you can actually strengthen your muscles. Which is the exact opposite of what many physical therapists tend to do. You need to exercise more, but it hurts. That's because you don't exercise enough. But it hurts. I can't exercise, it hurts. So patients, again, are being blamed with exercises that will never meet their needs because it hurts. Have you ever tried to do anything while you're in pain? It's not that easy. Try to take an exam with a migraine headache. Good luck. I believe that in my patient with Ehlers-Danlos syndrome, the best approach I can offer them as a physical therapist is to get rid of their pain first before I ask them to start loading their body. Once they're pain-free, then they can actually be successful in exercise. But in our clinic, we do a lot of what's a technique called dry needling. We do a lot of laser treatments with these patients. We do a lot of manual releases, and we do a lot of education. Along with that, we do consult with patients about their stretching habits. Ehlers-Danlos patients should not stretch. That's really bad for you. You need to stiffen up. The more stiffness you can get in your joints, the happier you're going to be. But I think they stretch because of these taut bands of these areas.